Heidi is a breast cancer survivor and advocate. She highlights treatment options, quality of life, and community concerns. Heidi, over to you.
Hi, thank you very much. Thank you, doctors. I just want to say thank you for your work in this field. This is obviously crucial. My first question focuses on accessibility and briefly touches on what Priya had mentioned just earlier. There are so many people groups out there that just simply don't have access to, larger institutions that are conducting this kind of work. But it really is, it's incandescent and life-changing, this arena. Do you have any ideas how to propose that we can reach the underserved where they are? Simply because if they have cancer, for example, they can't, they have such financial toxicity, they don't have the wherewithal to get to organizations that might be conducting precision medicine. Can you speak to that just briefly?
Yeah, so I think there are really exciting things happening right now in diagnostics where we would measure the genetic or genomic changes associated with an individual tumor. The cost of some of these tests, whether they're DNA sequencing based or I'll highlight another version, have dropped dramatically. There's a specific startup company I'm thinking of as an example that is leveraging new enzymes, so not DNA sequencing, but a new form of a test that relies on specific enzymes that we can harvest from bacteria that we can program to detect mutations. And this has been demonstrated in field trials in Africa to be able to differentiate between different subtypes of Ebola, or in Southeast Asia between dengue subtypes, as well as in the U.S. To differentiate between different serotypes of HPV that are associated with cervical and head and neck cancer. And the appeal of these approaches is that they're very low cost and they can be done in the field with no specialized equipment. So the estimated cost right now for these tests is about $10. No specialized equipment, no refrigeration. You get results within a half an hour. So if we can implement these at scale and we turn this from a small startup of 10 people, I'm not financially involved in any way, so I'm not trying to plug that for that, just to be full disclosure. I think that these enzymatic tests can be implemented in any clinic across the world, really, and I think that would be amazing for medicine outside of North America.
Yeah, and I'll just to speak to that question. I think what we don't see often is the etiology, the cause of the cancers that we think we know a lot about in other countries. One of my colleagues, Catherine Van Loon, here at the UCSF Cancer Center, goes to Tanzania twice a year, every year. She's a medical oncologist, and we've now sequenced 200 genomes from Tanzanian squamous cell esophageal cancer here at UCSF. And, we think that some of the causes of esophageal cancer in Africa may be different than those here in the U.S. And so I think at a very fundamental level, this isn't the kind of high-tech, fancy, state-of-the-art kind of medical center you think about, but actually using the power of the technology to go global, as Dr. Gilbert's alluding to, is really the first step, to use technology to pull these populations up to a minimal standard of care and then building on that.
Going global, would that not be just fantastic? What a dream. I had a question, but based on what, I can't remember which one of you said this earlier, I kind of want to dive into this instead. One of you, we were talking about, the quote was exactly, we guard our medical info. We're really tight on that because of the, different laws and everything here in this country, but we want to liberate our data. I'm not sure which one of you was talking, which one of Dr. Eric or Dr. Luke, but that was brilliant to me. As a patient, as a two-time, someone who's been diagnosed with cancer 2 times, going into, let's say a patient is going into a surgery ahead of time and they know that, they've been diagnosed with cancer, now they're going in to remove their tumor or tumors. What, if the onus were on the patient, what can we do before we go in to say, we want to free this tumor? I want to make sure that all the precision medicine that needs to be done on it can be done so that you can dive in and, all the functional testing, make sure that you test those tumors with, outside drugs. so I know what will work. Is there something that we as a patient can do before we go into those surgeries so that we get precision medicine?
Yeah, so there are a few of these projects that are growing. My colleague Nikki Wagel at Dana-Farber has a great project in breast cancer called the MBC, Metastatic Breast Cancer Project, where patients are consented and they send their tumors in, and he and his colleagues in Boston sequence that tumor, and a proviso of participating, I believe, is that data becomes public. And so the germline component is kept private, but the somatic mutations are shared with the public, so that clever researchers in the Czech Republic, for example, who may not be hanging out in Harvard Square that afternoon, can have access and think about those data. We're aspiring to that in other diseases, pancreas cancer being one of them. And it is a delicate balance, because a lot of these diseases, like we just talked about, have a very strong family risk. So it's fine if the patient says, yeah, I want to share my data, but that doesn't mean her daughter feels the same way or her sister feels the same way. And, genes are tricky things. They get mutated in cancer, but they also get shared in families. So finding the right spot between transparency and privacy is something we just need communication. We just need dialogue. And I feel, unfortunately, we've kind of locked down the dialogue a little bit too much on the privacy side with some of the election shenanigans. But hopefully that will open back up and we can actually have a civil discourse on this topic.
I agree completely. As a very passionate patient advocate and a breast cancer community organizer, how can we, my little narrowly focused group, what can we do to help both of you as this progresses, and the other groups that are out there in the precision medicine space, everybody that's out there working on testing everything, what can we do to help you?
That's a tough question. There are a lot of these trials coming up that have to do more with you. What can we do to help you as the breast cancer patient, survivor, et cetera? I think we haven't done as good of a job beyond saying, send a check, of what can we actively do to enroll patients. Some colleagues at UC Santa Cruz are trying to gather all the BRCA alleles, called the BRCA Challenge. I'd encourage you to Google that. And it is especially for Asian women with breast cancer who don't happen to be Ashkenazi Jewish. They have an allele of the BRCA1 or 2 gene that looks like it might be cancer, but we don't sequence a lot of Vietnamese women, so we're not quite sure what to do with this. And so it's through this kind of crowdsourcing approach that we're trying to adjudicate what alleles are deleterious, and that's very much community driven. In other diseases, we're also trying to certainly support each other, more through traditional meals and rides to clinics and donating rooms so people can participate in clinical trial. But I do agree we need to be more activist on the genomics side, and we're trying to build the infrastructure for that.
Very good. Well, I'd love to stay connected with you. If I could do anything to help, please consider me at your disposal.
Well, thanks for so much you already do.
I would add at a national level, a lot of the research in medicine, research in science and research in medicine is funded by American taxpayers. And so I think 60 years ago or 50 years ago, there was a decision by politicians and American citizens to fund cancer research, and this is worth it. We've made a lot of progress, but I'd say that it's been reassuring over the last couple of years that commitment to cancer research has been renewed or is continuing to be renewed, but it's something that politicians do need to hear that people care about, right? And it's important to communities.
Yeah, it is pretty incredible in 2019 that there's any topic with universal agreement. But I would say that supporting cancer research from the far right to the bleeding left side, both are firmly supportive, and there's just no disagreement on that topic.
Yeah. Full disclosure, I sit on the Department of Defense Grants Review Board for Cancer Research, and I did not pay you to say that. It is just absolutely wonderful.
Good, yeah. Keep up the good work.
Thank you.
Thanks for your service, too.
So I have a question about functional testing. If they test a tumor outside, like during surgery, what is the accuracy level when they do the testing that they know if a drug will work inside the patient? If it's outside the patient versus inside.
That is a really challenging question. What I tell people is that everything except for a real human tumor is a model, and we've learned a lot from models, from simple models and from complicated models, but in the end, any model doesn't recapitulate the complexity of a tumor in a human, and so I think we've come a long way in our understanding of how to use various models to predict drug efficacy, but it is one of the central challenges of cancer research is how to pick appropriate models, and it's a balance of complexity and cost and throughput and which questions you want to ask. It's very, very, very challenging.
Yeah, I will say, I'm a consumer. I like trying new things as an oncologist, and I like gadgets and new tests. I will say I haven't seen a commercial product that proposes to grow cells and treat them in a way that I think is currently clinically useful. That certainly doesn't mean it will never be a true statement, but today I don't think we're there yet. And that's largely because it's kind of at least two problems. It's one is getting the cells to grow, which is not at all trivial. And then second, is the testing you do on the cells predictive of what's going to actually have to happen? And unfortunately, that's a conditional question. If they don't grow, then you can't even ask the second question. And we've learned that not all cells grow and that is not random. So some of the patients in whom we most need this kind of a service, again, pancreas cancer, for example, are actually pretty tough to grow in a dish compared to leukemia cells, for example, which can be grown relatively easily. So yeah, I think it's a promising model. I will add that a lot of Luke's research is a similar version of functional testing where he actually tells us on a genetic level what kind of mutation should we expect if this therapy works and then the cancer recurs. So that's another kind of functional analysis where we're using a known medicine, but we know it's not going to work forever, and I think Luke's research actually tells us what trouble lies ahead so that we can plan the next therapy appropriately, and that's another functional medicine that is very helpful.
Or even better, as best case scenario, our research predicts for new medicines how they should be combined with existing medicines to have synergistic anti-cancer activity. And so one of my goals is to continue working with clinicians, scientists, and chemists to build innovative medicines that are really non-toxic, but which enables them to be combined with other therapies. So going back to this KRAS example that I highlighted, this drug in people or in animal models is completely non-toxic. It's safer than Tylenol or aspirin. They've never hit a dose-limiting toxicity in people, and so that's my 2019 example of the direction we want to be going in cancer biology.
Absolutely.
Non-toxic those are like words to my ears, having been through so many different types of chemotherapies. That's amazing. I was speaking recently at a clinical trials event in Philadelphia, and one of the questions kind of surrounded what I mentioned earlier about underserved populations and how they, may or may not be reticent to come forward or simply can't come forward. Can you kind of just elucidate the steps we've taken? I know that we kind of, the pendulum has swung pretty far about keeping privacy and things like that, but how far have we come from like the Henrietta Lack situation where we're not going to do anything nefarious with your tumors, but we really want to help you? Can you kind of just speak about what has been put in place to to encourage people to participate?
Yeah, sure. I will say there's more sticks than there are carrots, unfortunately today. So it is against the law to discriminate against people based on a mutation they have, and that means I can't refuse to insure you based on a mutation. For example, I can't not give you a job because you have a mutation in gene X, and that's a fine law to enact and well intended. Unfortunately, it's not totally symmetrical with what Luke and I are telling you today, right? We were just talking about privacy and the laws preventing genomic privacy, requiring, non-discrimination based on genetics. And at the same time, Dr. Gilbert and I are telling you that it's genetics that causes all this stuff, or a great deal of it. So at some point, it's certainly not all genetics, but to say that genetics is equal amongst everyone and that there is no increased risk in person A versus B is just scientifically not true. So I don't think we've had a high-level discussion over how to reasonably factor in genetic risk into things like insurance premiums and stuff like that. It is clearly non-zero, but our laws today assume that it is zero. And I think we need to have a bit of a more mature discussion over that.